So anyway, welcome to NUR203 Pediatric Nursing. I am the lead pediatric professor. I actually met our dean when she came to Cutler Bay in Florida, and we worked together on ground together before we were an online program. And we just hit it off. And when they went to the online version, she reached out and asked me if I was willing. I don't think I finished the email and sent back the yes within seconds because I went to get my higher level degrees so that I could teach online. I've been a nurse forever. I graduated nursing school in 1976. So I have seen so many changes. I have seen IV tubing with a little blue roller clamp, which is all you had, to go to everybody gets IV pumps now. And I think that's the neatest thing. Because I used to have to count drops between seconds between drops. And I knew every 3 seconds a drop would drip. It's the IV at 125 mLs per hour. I mean, I remember it to this day. So having just this one thing, how about all the invasive monitoring, medications, procedures? So nursing isn't just nursing school, learning it and getting in. It's an ongoing understanding and keeping yourself up and abreast. That's why you have CEUs, and that's why hospitals, all these in-services, et cetera, to keep you abreast. Most of my career is pediatrics, but I did do 15 years of adults. So I'm a very different nurse. There's not many of us. I do adult ICU, ER, and I also do pediatric ICUs. Cardiac ICU is my favorite, newborn ICU, PD ICU, and the last 10 years was in a trauma center pediatric ER, which I loved. I was a trauma nurse junkie, and I loved being the primary and being in control and getting these children's saved and rescued. And I just thought it was fun. And it was because I was the calm in the storm. And I would get this, get that, go that, look at this, get this. And I would get everybody running around, but very calmly. So I've enjoyed nursing, being in the hospitals, but I suffer from rheumatoid arthritis. And, there are bad days with me. So today I get to teach you and share my experiences with a bunch of students. And I've always been a teacher at the hospital. So now it's just, I'm still teaching. So I'm enjoying myself. I started with Fortis in 2017, and I started with pharmacology, which I said, yeah, I guess I could fake that course, and pediatrics. And with pharmacology, I learned it quite well, learned how to teach it good, but my strength in pharmacology is dosage calculations. If you do not know how to do dosage calc, come to me for 15 minutes and I'll make it very understandable. I do not use ratio proportion, all that add in, cross off thing. It's pull these numbers, and I have 3 formulas that'll do everything. So I will be sending you those recordings that I have that you can look at. If you want the worksheets that go with it, ask me. And if you want to meet me, whenever you can, I'm not going to keep you for an hour, 2 hours. You don't need that. You just need me to show you what to do. Then you need to practice it because I understand you guys are busy. Not only are you in an accelerated program, many of you have families, responsibilities, work, and work overtime. And I know that. So I will not take up your time more than I have to. But I don't see why anybody gets 2 points off per question for dosage calc, because that's how easy I make it. So how do I teach? Well, I'm sure some of you have heard about me and Professor Bogart, the way I teach. Well, I make it very simple. I make it very understandable, and you're going to hear a lot of stories. Being a nurse for, I don't even know how many years anymore, 40 years, 50 years, I don't even know. Um, but I'm only 29, okay? 29 forever. But I've been around, I've got stories to tell you, and I think they really make what I'm teaching you more realistic, okay? Now, something just came up, somebody had to leave. I don't mind if you need to get up, go to the bathroom. I don't mind if you have something to drink, something to eat. Many of you are running home from work or from somewhere else, and now is your time. It does not bother me. Okay? As long as you come to class, you're listening, paying attention, asking questions when you want. That's the least of my worries. I want you comfortable too. I mean, I have my jug of iced tea. I'm a happy person. So whatever you need, it's fine, okay? I do a PowerPoint to start, which I do give you at the beginning of the week. I know some of you like to print it, have it. Some of you just like the digital copy, whatever you want. I redo these PowerPoints, go over them, look at them, making sure that you have all the information you need for exams, quizzes, and EST, and of course, ultimately your NCLEX. And being with Fortis now for, is it 8 years now? um, I know that I know what concepts you're going to see. So I've tried to pin it down to try to be able to explain it. So you're going to get a PowerPoint, and I do quote a lecture. But at any time you don't understand, or you have something you want to input or say about whatever, do not be afraid to come in and ask. I do not like it does not bother me that you interrupt me because it's not interruption. Because if you have a question, a comment, I think we all benefit from it. And it might be the other person who was too shy to come in. So if you need anything, please stop me. I encourage you so that you can understand and learn. Maybe I don't explain it as clearly as enough. I can explain it in a different way. Just let me know. When I'm done with the PowerPoint, I will go to a Kahoots. Now, this Kahoots is going to be on the information that you are going to just have. So if you come to class prepared, looked over the PowerPoint, maybe read some of your chapter, come prepared, you've seen the information once, I teach it, that's 2 times you've seen it. Now you're being tested, quizzed on it right away. It gets that, understanding, because it is known that students learn from repetition. Some students like visuals, some like stories, some like games. I'm giving it to all of it to you. And again, you will get the Kahoots, you'll get everything from me. Whatever I have, if you don't get it, let me know. I know some of you didn't get some of the handouts. Just let me know. I'll send it to you. It's not a bother. You can always ask me for those things. So today we're going to be doing first the PowerPoint for online learning. I'll give you my spin on it. I'm sure, have you all been in community already? You've heard it once already. All right, so I'll go over the stuff that's important, the most important. So we won't dwell a lot on it. You're gonna have that, you have the PowerPoint you can go back and refer to. Then we're going to go the PowerPoint for the day, and then I'm going to do my Kahoots, and we'll be done. Now, I have a question. When I teach, I can stop in between PowerPoint Kahoots, take a break, and we'll get out at 10:30. Or we can go right through without a break, minding, I don't care if you need to get to the bathroom, get something to drink, do what you have to do, come right back, to listen, and we'll get out about 20, 25 minutes early. What do you want to do? It's for me, it's 10:30 at night. So whatever you want. But you have to tell me, do you want a break or no break?
No break.
No break.
No
My
break.
vote. No break.
No break.
No break.
Okay. All right. I think that's pretty good. All right, let's go ahead and start. So far, any questions? Did I elicit anything that you need to know about? Okay. So online, this is a new PowerPoint that Dean Brown made. There's some redundancies in it. So I'll go over what you need to know. Well, you know that if you have any problems in this course, number one, and I'll say it probably at least 10 times during this PowerPoint, anything you need, communicate with me. And when you need something, communicate before something is due. If it has to do with coming to class, taking an exam, taking a quiz, having assignments handed in, talk to me before it's due. I can work with you. And then we could give you extra times without penalties. Or with a quiz, not being able to take that quiz. That's one of the most important things. Talk to me, communicate with me, let me know what you need, and I can help you. So remember, when you come to class, always plug in your computers If it's going to be on a test day, make sure even your your phones are plugged in. Many times phones will, the battery will run out. And anytime that I don't see you on screen, especially during quizzes or exams, that is taking it off screen. That means you probably get a 0. So don't do that to yourself. Make sure things are plugged in, okay? Now, if you can't get a hold of me, something you need, something's important, and you need to speak to me, or something happens and you don't like something, please, I am the lead, so you can't go from somebody to the lead. You go directly to Darlene Brown, please. Darlene Brown, Dr. Brown, is the dean. I don't think she sleeps. And I will not be offended because you need something, please talk to her. All right. And then she will communicate with me and we'll come up with whatever is an agreeable agreement for all of us. Okay. So always remember, communicate. Can't get a hold of me. It's important. And remember, there's always Dr. Brown. This is her information down here, her phone number and her email. Now, most emails are like me on bbogart@fortiscollege.edu. She's the complete Darlene.Brown. There is another D Brown at Fortis College. So it'll go somewhere, but not to the right person. So just be aware of that. And don't be afraid or hesitant to call her. If she can, she'll pick it up right away. If not, she'll pick it up as quick. She'll answer you pretty quickly. I don't even think it goes a day before she's answering you back. And of course, if you need to, always the campus dean. And I do actually meet with all of your deans. I know Dean Rock, I know your deans and all the campuses. So it's not a problem. We can communicate. Okay. The one thing I do ask is be courteous when you're talking to me, state your issues. I'm going to listen. I'm not going to be here, like everything I say is, golden rule. Sit there, tell me what your feelings are. And something, I'm going to listen. And just the way you're going to listen to me if I'm talking to, right? And then that simple humor of, "Oh, no, don't give me those messages in all the caps, right? Now, I do have a cell phone. You may use it. When should you use it? Well, if you can't get a hold of me on Canvas or email, send me a text if it needs to be that urgent. And you could call me at 305 951 8055. That is also on my biography page. So it is there for you to use it. But remember, use it for things that you need now. You can't wait. You're having a moment. Or that's the only time you can do that assignment and you need some explanation. Please do it that way for me, okay? And I do answer pretty quickly. Remember, discussion boards are like tonight, you should have done your first discussion board. If you've not done it, don't worry the first week. And then you have to do responses to 2 peers. Those 2 peers, I've been said, do I do it later on? Can I do it the same time? Whatever works for you. Okay. There are some instructor that want you to first do it on Wednesday. Get that in by Wednesday night. Now, if you could do your your peer responses, go ahead. If not, just make sure you go back and do that for me. Now, one of the things that has been a big deal is academic integrity, always, cheating, plagiarism. Remember that, and I did send an announcement regarding some of these websites. I want to caution you if you want to go on them. Number one, you shouldn't, because it's really cheating. And I want you to know EA does monitor these sites and they have students were released from the program because of these websites. And I don't want any of that to happen to you. Cheating makes it easier, but in the long run, you're cheating yourselves. Because remember, at that NCLEX, you're going to be sitting there alone and you need to know that information, okay? So try to do the work, your own work. Don't try to copy others or copy stuff that you find on all of these crazy websites, okay? Be careful, be very careful. They already have a list of 500 students from Fortis that have been on there. So just be aware. And basically it's a code of ethics, just, making sure, those things also. Again, cheating, again, it's there. It's telling you the websites that are there. Again, I've just expressed it. Be careful, don't do it. Your assignments do go through plagiar checkers, and we do see it. And even I monitor these sites, to make sure, because if you're not doing the work yourself, you're not learning anything. And the idea is to learn. Now, on ground, sometimes there's different rules, okay? But in online, if you hand in your homework when it's due, you will get full credit. If you go over 1 week, you have another week to hand it in with minus 10% deduction, unless you let me know Sunday before the assignment is due. I'm in the ER with my daughter, or this happened and I can't get it done. Can I have extra time? Notify me before. Now it can't be every single thing that's due, but life happens and I understand it. You let me know, I'll work with you, and I won't minus that 10% deduction. But after week 2, late, it's going to be a 0. So you turn it in on time. You have 1 more week to hand it in minus 10%, or maybe not if you've talked to me, and then it cannot be opened. So once it's gone, and you will be getting a 0 for that section. Remember, this homework is 20% of your grade. Be careful. We have had what we call homework fails. They do great quizzes, exams, don't do homework, and they fail the course because they're not getting their stuff done. Now, one of the things that I was doing earlier is about signing in on Zoom, making sure that you do it properly. As I said, I'll look at it and I'll help you. But if you see somebody comes in and I didn't catch them, please let me know so that I can get their whole names in. Because we do download Zoom logs and we put it in for attendance, and they look at it, and they make sure the names and the students were there in the class, because all your state boards have certain how many hours of instruction you need, so they make sure that you're getting it, and those Zoom logs shows the time spent in class. Okay. On my Zoom logs, I always say no break. So those little bit earlier, it doesn't count against you, because you're actually allowed 10 minutes per hour of instruction as a break. That is part of what the Fortis your handbook says. Okay. One of the things that is not understood is entering information into Canvas. Now, you need 2 points of entrance every single week. Could be a discussion question up here, could be putting in one of the assignments, but make sure that you are always, every week, 2 places put it in, because it's not only your attendance is me putting in the log that you're here, but it's also Canvas showing that you were showing points of entry. And they will say, if you're not posting anything, you're coming to class, but you're not posting anything in Canvas, 14 days in a row, you will be dropped, and they don't have to notify you. So please don't let that happen. If you're doing the work every week like you should, it is not going to happen, but just be aware. Another thing, if you have to be out attendance, and it's just for instance, last quarter there was Halloween. One of my students had to go out and trick or treat with his children. Well, I'm like, do you realize you're going to lose the attendance? Then I've had other students, they were having emergency surgery. Now, you will be counted absent for attendance, but give me documentation in the ER, have a car accident, or you took the dog to the vet because of emergent, whatever. Give me documentation, and then I can send it to Dr. Brown, and you're not going to be held accountable for those hours. As in, if it gets to 20%, you're not going to drop a letter grade because of that. Okay. Another thing, 1 minute late is 15 minutes. Leaving 1 minute early is 15 minutes. So just be very aware of time because 15 and 15 can add up to 20% pretty quickly. So just be careful. I will let you know if you're getting close. They're also going to be sending you 5, 10, 15%, you're over your limit, okay? So you're going to be very, very, very aware. And that's what this is all talking about here. Make sure you do something to keep yourself organized. This week, you just had to do your initial stuff, coming in, your little quizzes and your discussion questions. That was your homework for this week. So that's easy. But as it goes along and gets to about week 7 or 8, you're studying for an exam, studying for a quiz, doing this project, doing that project. This is due, that is due, CJ Sims. Oh my goodness, NCLEX. Do something to keep yourself organized. Now, I have myself, one of those big calendars, and I write on it what I have to do. If you want, do it digitally, whichever way works for you. I mean, you could program your phones. I've seen students print their syllabus, and when they have to do it, they have yellow, and when they're done, they mark it over in black. So it's all this color coding going on, so they know what's happening. Now, I send you reminders so that just in case you might have forgotten. And it happens. Life is busy. So I will let you know, but please try to keep up to date. Try to turn it in on time. Now, I do not send a lot of announcements. You're going to see like week 1 information, and you'll see week 1 recordings. Now, there was an extra one this week because of Dean Brown wanted us to write one about using those websites, okay? But usually I don't send a lot. If I send one, and some send a lot, if I send one, it's important. So pay attention to it. And we know to write down all my information, have it at hand, program my cell phone into your phone so that you have it in case you're out, something happens, you can't get to class, you're going to be late, whatever, so you can let me know. Now, I'll do tutoring whenever you want. I can do before class, after class, and I'll work with a time for you. So let me know if you're not understanding a concept or something you don't get it, or you need help with your math. Let me know, and we'll work together, and I will help get you through. You just have to ask for help, okay? So we do reviews before each exams. I don't do these weekly reviews. I have an open session all week. Whenever I'm open, I will help you if you're struggling. All you have to do again is ask, right? KGA, key graded assignments, unit exams, quizzes, and your HESI. Those 3 things add up to 80%. All the other stuff is 20%. Be very, very careful to get it in. Like each NCLEX question is 1.25% of your grade. And that could make a difference in the end, that little 1%, it does. And when we get to week 8 in the pediatric assessment project, it's 6% of your grade. So the one thing I do with that is I let you turn it back in, and I'll look at it, say, ooh, you should do this, this, and that. You come back, you revise it, send it back. You could get a perfect grade. Just I'll work with you, you work with me, we'll get a great project, and you'll get your 6%, which is, you want that in the end to help boost your grades up. Now, initially, we don't have any homework scores turned on because it doesn't behoove you to see it yet. Well, by week 5, we've had a couple quizzes and we've had an exam in. So in week 6, we turn those homework scores on, and it's going to show you how your homework affects your overall grade. And that's what it's there for. And then on week 8, we turn it off. Week 8 is by the end of week 8 is the last time to drop. I don't have many students that do drop. If you work with me earlier, you don't need to, but you got to come to me. You got to ask for help, and I will help you with that, okay? And then after week 8, they're turned off. They don't come back on until after the HESI and it's been remediated. I mean, you all know how to stick in your grades to figure out what you need on your HESI and all that sort of stuff. I can't turn one person on. It's all or none, okay? So that's not till after, be the final grades. Remember, it's a 78, it's the number that you're hooting for. Your KGA has to be 78, and then we add in your homework grades. So whenever you come in for exam quizzes, remember, have them on charger or have them completely charged. So I got to go run get my plug, and that just distracts from you, getting yourself and get you, anxious. Don't do that. Be prepared. Be ready for it. All right. Now, there are times that quizzes, exams, something happens, you had a power surge, your computer goes black. I mean, I can tell you bunches of things that have happened. If this happens, tell me immediately, as in, all right, your computer's down. Oh, you got my cell phone in your phone, right? So now text me. My computer went black. I can see quizzes and exams per second when these things are happening. I know how to go back and look at it. Now, you let me know right away, it correlates with what you're saying. I can reopen quizzes, and then your exams are never lost, okay? So don't think, oh, it didn't upload. Oh my goodness, I'm gonna have to take it again. No, it's there. We just call ExamSoft and they figure it out and we get your grade back. Because I've had maybe one semester we had to go back to ExamSoft. So don't worry about it. Quizzes are always the beginning of the class and it's last week's material. So your first quiz is next week and it will be on week 1 information. 10 questions, 1.5 minutes per question. It goes forward, you can't go back. And we do it that because it is just like your HESI, your NCLEX. We're getting you ready for your NCLEX by doing those things. And again, you go off camera for whatever reason, you get a 0. So make sure that you are charged. Or if something happens, you let me know immediately so I can help you, okay? Again, ExamSoft, we go through all of those reviews and we look at your ears and your hands and all these things before. We try to about 20 to the hour is when I come in for exams to go over, the review, your IDs, et cetera, et cetera. If you have accommodations, you need to let me know now so that we can prepare. I need to know what we need to do to get you. Do you want to come in early? Do you want another day, hit another class? What do we have to do that you get the time that you deserve? You just have to let me know, okay? Sometimes exams, some of them like them on campus. I need the person on campus who's going to administer the exam, that's the appropriate person, email me. Because without me being emailed, I don't know. They're not going to have access to the exam, and only I can give them the code to get into it. And it must be done about 3 days prior to exams. You guys here, most of you are usually come on Zoom. You're not usually the campuses, but maybe one of you wanted to. We already did all that. We know about lake work. We know about talking to me before, right? Don't talk to me after. I want to know before when things are happening. Again, communication. What do we do when we are a nurse? We communicate, right? With the patient, other nurses, physicians, in order to get the care done. And that's why we talk about it. The quizzes, we go through the modules, and we know that the exams are through ExamSoft Exemplify. Again, just let me know when something's happening, okay? Your HESIs. I've got some great Kahoots, and I've also got a HESI, what I call Q&A, that I set up for your HESI to try to help you think. So I've got a lot of stuff, and I actually have taken your concepts from previous HESIs, and I go back and try to figure out what could they be asking. And I make up this HESI Q&A, and I go over body systems, and I go over infants, toddlers, preschoolers. What are things that they might ask? to get you thinking. And I've had students tell me that it really helps. They can actually hear my voice when they're taking the HESI. I mean, if you do what I tell you to do to take this HESI, you will get over a 900. In fact, usually my mean scores for all of my students are over 900. So if you listen in class, you play the Kahoots, you know, listen to my reviews for the exams, you're gonna do great, okay? So just do what I tell you, and we're gonna get you just doing amazing. You know, you don't want to do 12 hours in remediation, do you? Let's just do that simple 1 hour and get it done, and that's at 900. So that's my goal for you. Again, talk to me, talk to me, talk to me, right? Again, make sure you know what you're doing. Whichever way you organize yourself, get it done. We know about late work. NCLEX questions. The first set of NCLEX questions is not pediatrics, it's under growth and development. Make sure that you're aware, and make sure when you're doing NCLEX questions, you're doing the areas that the modules are telling you to do, because I do look at that. And the other thing is, don't send me a sheet that looks like that little green square up here. I want to see the whole 5-page or whatever it is, okay? So if you don't know how to do it, and if you send in something that's not right, you're going to see a 0. Now, it doesn't mean you're getting a 0 on it. I'm going to send you a instruction sheet on how to do it properly. And then I'll put your what your real grade is there, okay? Willie, you have a problem?
Oh, no. So you just want us to save the PDF and
Yes.
upload that. Okay.
Yes. So it says print results, that bottom right. Instead of printing it, send it to a printer, it goes save to PDF. You save it and then you upload it into the your module into the NCLEX area. And that's the way it works. Okay. So if you see a 0 on your NCLEX and you put them in, something's wrong. Just go back and I'll write a message to you. I'll communicate very well with you. And it's not that you're going to get a 0. I wouldn't want that for anyone. So don't, keep breathing here. And as long as you upload it correctly, we'll get it right. And that goes with also your CJ Sims also. If it's not done right, I'll put a 0 and I'll tell you what you need to do or what is missing, okay? Once NCLEX questions are in, that's your score. You can't go back later on and redo it and give me higher scores. I highly suggest any assignment you send in, you have a minimum of a 78 there. You don't want homework grades to pull down your overall grade, okay? So just be aware of that. I know sometimes like you just want to get them done, and you're like, okay, so I got a 68, whatever. It might bite you, so be careful, okay? Again, NCLEX questions, I've already talked about it. We know how to do it. And we do have 2. We have a HESI exam. One's a practice, one's an assignment exam. They're towards the end. Now, these are done through the modules, and the scores should automatically transfer. Occasionally, there's a glitch, and it doesn't. Don't get upset. Send me a message. There's ways I can go into it and look at it and find your scores. Do never go to directly Evolve site, okay? It must be through the modules, okay? All right.
Professor, sorry.
Yes, it's okay.
Do you, for the NCLEX questions, do you want us, so if we do 50 and then we get 45 or whatever, we need to remediate or anything for them?
No, no
Okay.
remediations required. No.
Okay. So we
I
just
mean,
send you the 45?
Just send me the 45,
Okay.
Save as PDF, save it, and yep, send it to me. Now,
Okay.
what would I do if I got something wrong? I would look, why was it wrong?
Right.
And at least that you know it, but you don't have to write anything. No, that's
Okay.
you guys are doing enough. That's overboard at
Okay.
this point.
Okay, thank you.
You're welcome. No, very good question. Thanks for saying that. I usually do, but it's late at night for me. All right, CJ Sims, 4 things. Top right should be your name. You should see which CJ Sims. I need the date it was done, and I need your score. All right. Sometimes they're upside down, backwards. I don't care. As long as all those things are there, I'll go looking for it. There's one assignment. It is week 8, and it's the pediatric assessment assignment. Now, most of you know someone or are someone who have a condition that could be a pediatric diagnosis. I mean, like asthma, ADHD, diabetes, Crohn's, IBS, many things. And what I want you to do is start thinking about what diagnosis would you like to choose? Now, very interesting from my Monday class, my student sent me a message. Sorry, I was on the phone with a doctor. My son was da 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 da. So I asked her more questions. Come to find out that her family has this strain of diabetes, which is very unusual. I hadn't heard of it. So I said, there's your project. Something close to home you want to know about and research makes it a better assignment that you will have more fun with instead of I just got to get this thing done. Maybe you have sickle cell, maybe you have this, because remember, a lot of adult conditions are pediatric stuff. So find something you like. Follow the rubric. I do also. Make sure you use APA. In the discussion questions, you're going to see me. If you're not a perfect 20, why not? And I'm going to tell you why. If you want to learn how to do it, make an appointment with me, and I will show you how to get it so you get all your 20s, okay? On this project, I want you to have 3 different resources because you're going to be doing 3 parts. A paper, 250 words. That's it. Very small, brief to the point. Then it's a pediatric assessment. It's quite a few pages. But the most important part is, in the end, looking at theorists and looking at nursing diagnoses. So I always put my stuff, I'll tell you what was wrong in there. And the third part is teaching. Now, I've had students, you could either teach a nurse. Some of these diagnoses nurses never heard of. Don't think nurses know every of them. I don't know all of them. You see these different syndromes and stuff you've never heard of, right? Just like this diabetes type that I had never heard of. And you can do a PowerPoint, you could do a handout, brochure, or just a picture board. Again, put the references on there. Teach me something, okay? And what these questions here are talking about is we take what we're teaching and put it into practice like you're nursing. You don't communicate. It's like you're not communicating with a doctor. If you don't communicate, oh, I had to hold this medicine, or I'm seeing this condition, and you're not telling the doctor, something can happen. So if you tell me before, we can prevent these things, right? So that's what all of this stuff is talking about here. Being professional, being communicating, handing your stuff in on time, asking questions when you don't understand, okay? So that was that sort of about online. And I think what you really need to understand is that, online, we are like people behind a camera, but I'm here for you. All right. You have anything you need, talk to me, and I will help you. And if I need to hold your hand to get you through, I can. Tell you a story about last quarter. I had a student come to the first exam not feeling well at all. And she got a 46 first exam. She passed the course with a B. Can you imagine? And why? Because she came to me, we did tutoring, she went to the review sessions, and we discussed it, and she got high 90s on the rest of her stuff and scored over 1,000 on her HESI. So I think that's telling you something right now, isn't it? 46. I mean, she was my shining star, and I won't forget her because of that. Any questions so far? All right, let's go and do our PowerPoint for today. So there's a lot of chapters, and it's like, a lot of different stuff. Many of the stuff we're going to go over more in depth as we go along in the course, but it's just an introduction to pediatric nursing. Now, most of you probably are going to go on to get a BSN minimum and maybe go on for an MSN and be crazy like me and go for a PhD, right? But, and not necessarily, but one of the things that I found, I went back to school after being a nurse for 33 years. And I realized that I needed to do something and get higher level degrees so that I could support my income as I got older because I was a single parent and I don't have that big, 401k sitting there because I needed every penny to take care of my children. So I knew I had to do something. So I went back to school. And one thing I found out about was when you have children, I got somebody who's trying to get in. All right, hold on. Let me just send this person the Zoom.
I think it's Alicia. She just messaged me. I also sent it to her. She said she's been struggling for a while to get
All right.
in.
Well, I just sent her the Zoom too. Thank you so much. All of a sudden I saw a weird number. I'm like, I think it's a student because it's not unusual the first day. So anyway, why did I stop and why did I tell you this stuff here? Healthy People 2030, and you'll see, I think it was 2010 when I first started because I started back to school in 2007. Got my BSN, MSN, and then it went directly into the PhD. But BSN, MSN is all about papers. It's all about picking something that you feel wholeheartedly about. I mean, I'm all about kids and I'm all about injections and why are they afraid about them? I mean, my dissertation is school-age children attitude and behavior towards injections. And along the way, I actually developed a program for Huggies, like the diapers, but H period, U period, G period. It's an acronym. Help us give great injections efficiently and safely. And what I did and found, and I did research at my hospital, is that children did better before, during, and after injections when they were held by their parents. So yes, I'd have another nurse help me hold a leg or whatever, but that kid was not crying, not as afraid, less stress, fear, and pain before, during, and after, as evidenced by decreased crying. They didn't cry much at all because they're right there in mommy's arms. And to this day, it's still used at this big hospital system, Miami Children's Hospital here in Miami. So it was that I went into Healthy People. And you're going to see Healthy People addresses children, it addresses adults, it everything. And any information you need, Healthy People is somewhere where you're going to be pulling a lot of it for your research. So I'm just opening your mind to that so that you're aware of it. Like these are some of the problems. We know, of course, obesity, type 2 diabetes, kids are not getting up and out and running the way they do. They're in there with their, iPads and they're in there with their, Switch games and, phones. And I know my 7-year-old grandson, in fact, he turned 7 yesterday. He, loves, Nana, can I have your phone? And he's doing all sorts, I don't know what all he's doing there, Roboblocks and whatever. And you have to stop them and get them up, getting them out. And they're sitting there and just eating, and they're getting bigger. And it's becoming an epidemic today. We know kids, they're always having injuries. I mean, injuries in kids, number one is always motor vehicle, whether they're in a car seat, not in a car seat, or ran over by a car. These are all things, motor vehicles, all levels. And then you get the adolescents who are finally driving, right? They're going to run over somebody or get in an accident. And then, of course, violence, of course, vaping is the new thing that's coming out. And children do have mental health problems, and some of them are quite severe. These pictures tell you a lot. I mean, I'm in South Florida. Drowning is huge down here, that we really have to be aware of it. I mean, my grandson, who lived with me for a while, by age 2, was doing front flips off of the ladder into the pool with no swimmies on. And he knew how to keep safe in the water. And it was something that I was adamant about because of the drowning accidents I have seen. Health problems, I mean, the highest risk are those kids born tiny, those newborn ICU kids, premature, very low birth weight, low birth weight. Kids in daycare, what do kids in daycare do? They play with toys and they swap spit from toy to toy to toy, right? This toy, oh, here, I want that. All right, this kid wants it. And it goes around and around and around. I mean, kids put into daycare, you hear parents say, every week this kid is sick. It's because that's what they do. Is that a wrong thing? Well, they need to build up immunities, right? We know that they wash and clean into all, it doesn't help. I mean, kids, how do they explore the world? Orally. Their mouths explore the world, okay? We know poverty, homelessness, immigrants. Immigrants are probably some of the sickest kids I've seen in the ER because they're afraid if they come in, they're going to be deported. And we don't do that stuff. We take care of kids, we give them medical care, so really it's a big thing. Kids with chronic problems, they were premature, now they have respiratory, cerebral palsy, whatever. They have stuff that we need to help. And barriers could be, do I have transportation to get to the doctor? Do I have that $5 copay? It's either $5 copay or do we eat dinner, right? Infant mortality in the United States is high. It is higher than many other countries, believe it or not. And I've seen massive changes in newborn ICU, but more need to be coming. Neonates are the first 28 days of life, okay? After 28 days, we call them infants, and that's up to 1 year old. And after that, they're toddlers. But neonatal mortality is high because they're just born, so many problems go on. And then, we get in, it's less after 1 year old. Their bodies, their immune systems, we've already figured out they're getting on treatment. And we know that when it gets to 1 year old, the kids are healthier. The school age children, 5 to 14, they have more common sense. They know when not to do things. Toddlers don't. They're good. I call them the dive bomb kids. They like to get on top of the couch, jump off, and try to jump on the other couch across the room. They miss, they hit the floor and bang, right? And get a big old, lump on their heads. And that's what toddlers do. But that's all that exploration, right? But then get to adolescence. We know everything now, right? The adolescents, they're going to be trying, they're going to be looking to do things, they're going to be experimenting, they're going to be, oh, let me look at dad's gun. I couldn't look at it because I was too little. I'm big enough now. And then it goes off, somebody's hurt. And that's how those things happen. And then you've got adolescents all about body image. They're really conscientious about that. Depression, suicide. Homicides, suicides, big things in adolescence. And again, all those other stuff, homeless, poverty, low birth weight, et cetera, et cetera. Now, one of the things about pediatrics, and one of the reasons why many nurses don't go into it, is the parents. Because you can take care of the kids, but you've got parents and grandmas and aunts and uncles and all these people to work with, right? All for one child. Now, family-centered care is pediatrics. And no matter what you say, you're going to have a parent that's, of course, my kid, they're possessive, and they should be. And some of them can be a little bit obstinate, mean, hard to deal with. And that's the patient I always got because I could work with them. But, I admire that because they care about their kids. Family-centered care. Family is the only thing they know. The family recognizes that it's that constant in life. A constant in life is the family. They know what the family's going to do. They don't know what their friends' families are going to do, anybody else is going to do, but they know what's expected in their family, okay? And what is a family? We have all different definitions. Up till my grandson was 3, it was me, my husband, and my daughter and my grandson. That was our family. She's met, excuse me, a really wonderful, I love her husband. They just got married in Mexico in September. And now that's their family. But family is two women, two men, they're adoptive, they're whatever. That is whatever the family is what they say. And it could be extended with grandma, grandpa, aunt, uncle, friends, whatever. I mean, there's all different types. Now, pediatric nursing, you're going to be really that therapeutic communication. You're going to be there. You're going to be like the psychologist trying to help parents through especially difficult situations. You know, husbands and wives, they go through a lot. They're all think differently. And you're going to be there and be that constant. And they're going to learn your name and they're going to depend on you to help them through. And it's okay. It takes a lot out of you, but you know, there's no better feeling when you can help a family to help their child to get better. One of the things I have always done is from the moment I meet a child, I'm going to sit there and talk to the kid, but I'm actually talking to the parents and telling them what I'm doing, why I'm doing it, and what I'm looking for. And when I do that over and over again, these parents are going to learn, oh, she's listening to the heart rate because I have to give digoxin and it has to be high enough. And I'm asking this and this and this and this because of, you know, what I'm doing. And they learn. They want to learn. They want to do well. And of course, teaching injury prevention because some parents just don't know they should wear a helmet when they're riding a bike. They don't know. Go figure. One of the things about kids is trying to do what we call atraumatic care, as in give less pain. Well, wasn't that program I did, Huggies? Kids don't have pain or as much because we distracted them by a hug and a hold from mommy, okay? One of the things with pediatrics is we want to reduce the distress, the physical distress, and do as minimal harm as possible. So, family structure, we've talked about what they are, you know, and one of the things I've learned is, you know, I came from a place where there was one culture. There wasn't these multitudes, Hispanic or Asian, or it wasn't. And I had to come to Miami and I married a Cuban, go figure. So then I had to learn the Hispanic culture and what to do with it, right? And who Abuela was because she was so important. And then I divorced him, and now for the last 20 years, I'm with a Jamaican. So all of a sudden, I'm with all these cultures. Then you go to the hospital, and in the hospital, there's all sorts of cultures, and you need to know how to work with them. And you know, one thing I have learned, if I don't know, I'm going to ask. And these parents and children respect that. You know why they respect it? Is because you cared enough to ask. And that in adults, children, it goes without saying. You don't know, ask. You don't have to know everything. And if you don't know it, say, you know, I really don't know. I don't want to give you wrong information. Let me find out and I'll come back. They respect that instead of you trying to go blah, blah, blah and say nothing. Okay. One of the things about families, they're going to be there. You need to know who is the role in there. Is it the grandmother, the abuela, or is it the mother or the father? Who is the one that you need to address? And can you look at them in their eyes? Some of them you can't, okay? And some of them won't look at you in their eyes for disrespect. So it's understanding these sort of things, okay? Everything influences children, okay? And influences the family. But we need to try as best we can. We don't learn it overnight. It takes time, but to understand, you know, what can we do to help make their maybe hospital stay better? Or maybe it's an emergency visit that's pretty serious. And we need to know, how can we take care of this family? Are they going to go bonkers on you? And now you have a crazy family down in the ER screaming and yelling, and you have a child who's not doing well, and it's it's not a good thing. So how do you control all those things, right? What do you do? Now, I mentioned it earlier. Let's see if you can figure out which one's the answer. A frequent health problem of migrant children and adolescents in the United States is migrant children. What do you think would be a problem? Again, this is cultural, understanding where they came from. The answer is tuberculosis. Because do they have TB testing like we do? Are they from Sweden? Or are they from Mexico? There are differences. Another thing is I've learned the way they take care of their kids due to different things is different in cultures. We know that there are some that have special diets. They don't eat meat, they don't eat pork, they are only vegetarian. Um, they have special herbs, teas. For instance, this herbal stuff. For instance, my husband, he likes to do garlic ginger teas when he's sick. Well, what did you learn in pharmacology about the G herbs? They promote bleeding, right? Well, what if this child or even adult needed to be placed on Coumadin? It might be a problem, wouldn't it? And now they're going to bleed out. So understanding culture and what to ask can help you take care of the child. And then some of them have their own rituals that they need to do. Is it part of the way they pray? Do you need to give them time, work around it? You need to respect it. That's time that they need, helps them, mentally get better. Another thing is that a culture that doesn't want a man taking care of their daughter? That's a big deal. Or when you're doing your assessment, how much do you uncover as you're doing that assessment? Maybe just little pieces. These are all things that are real that's going to happen. Another thing that I found interesting in the Hispanic is you go outside and it rains and you get wet, you're going to be sick. Or if you wash your hair and go to bed with it wet, you're going to get sick. Or if you walk on a tile floor without socks or shoes on, that's why you have a fever. And I see Elizabeth shaking her head, and yes, very Hispanic. So usually abuela is going to take care of the kids when the parents go to work. Okay. I'm the abuela who does it for my grandson. So I know. Anyway, and usually this has to do with fevers. If you take the socks off and let them walk on a cool tile floor, it draws out the heat and decreases the fever. And if you take off those 16 pieces of articles of clothes and hat and mittens and who knows what, fiebre muy alta is what we hear. That means fever is really high. Well, if you keep covering it up, what's going to happen? It's going to go higher. But explaining it in a manner that they all understand. So when the kid goes home, you give them the antipyretic, take off the clothes appropriately, let him walk on that cool floor. The kid's going to feel better. He's going to drink. Oh, grandma's happy now, and going to eat her soup. And now she's really happy. And when the fever goes up, they're not going to. And that's that hot, cold sort of thing that goes on. So these are cultural, but these are things I've learned through teaching, okay? Another thing that we'll see is I had 10 years in the cardiac intensive care unit, my most favorite place of all. I just see hearts in my head. I just see the blood pumping around. I'm one of those crazy people. And I worked night shifts, so I was very autonomous and I had a lot of fun working it and figuring things out and knowing there's 6 different ways to do one thing and what's the best way we should do it, and communicating with the physicians regarding that. But many times these kids come in and these are kids that are sick. They're going to be in for the long term of care. Some of them won't make it out. So baptism, some of them will offer. I mean, sometimes I'll say, do you believe in baptism? Would you like me to get you a priest, a rabbi, or whoever minister or whoever to come in? Very important. What about Jehovah's Witnesses? What do Jehovah's Witnesses believe in? No transfusions, right? They think blood is the soul of another human that you're putting into their child's body. Now, think about that newborn ICU premature infant who doesn't start to make their own blood cells till after 4 months of age, okay? And they're premature, so that's probably 6 months later, right? And their hemoglobin hematocrit is now 8 and 24. It's getting lower, maybe 7 and 21. Now they're being symptomatic. They're stopped breathing, apnea, bradycardia. They need blood. You ask the parents, they say no. So you go to your risk manager, we get a court order, and we can give blood. Are you going to take that blood bag and show it and wave it in that parent's face? Oh, absolutely not. Now, I've done it on night shift and I've done it on the day shift. On night shift, I'll tell the parents to go home and to call me up at, say, midnight. I'll be done and let them know that everything went well. And I won't have any of that stuff hanging around. It'll all be discarded, so they'll never see it was given. I've done it on day shift where I have the parent walk out of the room, had another nurse, did what I had to do. I hung it up. I put blankets all over the tubing. Even the baggie of blood that was left, I hid so they didn't see it. And that parent, 18 years later, it was the last day I worked in the ER, came in with her son, and I remembered the name. I don't know why. I don't know where my car keys are, but I remember my children's names. It was one of my kids. And she said, Betty Boop, because I was known as Betty Boop, because you'll remember that. So goes, oh my goodness, I've been looking for you for so long. And she hugged me and she said, I just want to thank you for everything you've done. And you just retreated with me with so much respect, and I'll never forget you. 18 years later, I was blown away because I didn't put the blood in her face. And I understood how difficult it was for her. Okay. So again, understanding parents, but getting your kid what they need, your child, your patient. We're all in counseling, that's what we do every day as nurses, as pediatrics. I mean, we do it as adults too, but a lot more because you've got parents and grandparents and friends and, you've got your little kids you're taking care of. So, leading cause of death among African American boys ages 15 to 19. What do you think is the leading cause?
Firearm.
It is firearm. Suicide is second. Absolutely. Because suicide, that's depression, and it takes a lot to get to that point. But firearms, it's just, they're reckless behavior. That's what they do. Adolescents, we know everything. I still remember my kids as adolescents. Oh my goodness, hardest time. I held on for the roller coaster ride, as I called it. But today my kids are both amazing, so I did okay. So growth and development. Think about a newborn. They're born at 7 pounds. They can't even lift their head up, right? Maybe they can put their fingers in their mouth. That's about it. By 1 year old, they've tripled their birth weight and they're walking or almost walking. Wow. It's interrelated, simultaneous, ongoing, and you're going to learn certain things that you need to look for, okay? Because if they're not doing what they should do, for instance, one of the things that we talk about, and it will be next week more, is about fine motor and gross motor skills. Well, fine motor is F fingers, what they can do with their hands, okay? Gross motor is what we call get up and go, 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 like Paw Patrol. That means lifting your head up, rolling over, crawling, creeping, walking. Usually, they can lift their head up with head control 3 months. They should be able to put it up there, move around, and hold it well. Now, if they're 6 months old and you take their hands and pull them up and their head falls back or it lags, there's something wrong. Now, we can do all intervention to look, but usually it could be something as simple as giving them an early intervention physical therapy or occupational therapy What if they're not talking? We got speech therapy. So kids are great. You give them a therapy, they're going to catch up with the other kids usually pretty quick. Both my first two grandsons needed speech therapy. You can't shut them up now. I mean, that's how great it is. But if mom didn't put them in it, maybe they'd still be behind. So understanding these milestones, which we're going to learn more about, it's in your reading for next week. Chapters 31, 32, 33, infant, toddler, preschoolers, you're going to see things that these kids should be doing. And if they're not, guess what? We're going to tell the doctor, and we're also going to institute an early intervention. The earlier that we institute, the quicker they come back to where they should be. So growth is how they're big. Now, height and weight are done every visit on children. Adults, no, they really don't care. They'll ask you, so how much do you weigh? I can lie every time. It's great. But infants, children, adolescents, you go to pediatrician, they're going to get an accurate height and weight. Why do we do that? Well, are they eating enough? If you don't eat enough, you're not going to grow. Now, if you're not growing, you're not feeding the brain, your cognition's going to be slow, right? Or maybe it's thyroid, maybe it's growth hormones, maybe it's some other condition. So height and weight are important. It measures so much on children, and that's why it's done. And that development is knowing that they're doing what they should do. And it goes from head to toe, cephalocaudal, lift their head up, roll the front to back, back to front, up on their knees, crawling, creeping, walking by 1-year-old. Maturation is getting big, and of course, the differentiation is they're all getting, changed up their bodies. Now, patterns of growth, directional, is how we grow, right? The sequential is what I just said. Lift your head up first, roll over, front to back, and then we're going to be learning next week what are those time frames. Like I've already said, that head control should be about by 3 months at the latest. And then turning from their abdomens to their back should be about 5 months, and then back to abdomen should be about 6 months. And by 8 months, they should be able to sit unsupported. Now, if they're a year old and can't sit without being propped up with stuff, something's wrong, right? So we need to look, is it neurological? Is it nutritional? Because if you don't feed the fuel to the brain, they're not going to be cognitively where they need to be, okay? Now, growth and development in children. I did send you a vital sign sheet. Why did I do that? It's something I found on the internet. Children, when they're born, heart rates and respiratory rates are high. 140 to 160 is their heart rate at birth, at rest, asleep. And the respiratory rate, 40 to 60, at rest, asleep. As they get older, those numbers come down. And blood pressure at birth, 60 over 40, normal. And then we know what adults do. So why do we need to know these numbers? Well, don't you need to give some medications like digoxin? Don't you need to know what's a good heart rate? What's not a good heart rate? Correct? So these are why we need to know those things. Temperature, a young infant, we need to make sure they're covered. An older one doesn't need it, thermal regulation. As they get older, they need less sleep, less rest, right? And remember, and I think you've started to hear this, nutrition is the single most important influence on growth. If you don't fill the gas tank, the brain ain't going to work. They're not going to do what they should be doing because they don't have the fuel to do it, because that's what nutrition is. And nutrition for the first 6 months is breast milk or iron fortified formula. And we can monitor that by developmentally, what are they doing? And if by 6 months they've doubled their birth weight, you're doing good. All right. What if they haven't doubled it? Let's say born at 7 pounds and at 6 months they're 10 pounds. They should be 14. they're not getting nutrition. So you need to do things to change nutrition to get them the amount that they need to gain the proper weight. What if they're not 14, but they're 18 pounds? Well, mommy, you're overfeeding this kid. What are you giving this child, right? Because that can lead into other problems or other things to look at, growth hormones, pituitary tumors, et cetera, et cetera, et cetera, okay? We know kids are all different. You get the easy kid and you get the hard kid, and that's just part of human nature. Now, I talk a little bit about it this week, but it's something you need to look at. If you want, I know one of my professors has many YouTube channels on Freud, Erikson, Piaget, and Kohlberg. And these are theorists. And what they do is they describe infants, toddlers, preschooler, school age, and adolescent children and what they should understand, the way they think, and the way that they put the pieces of the puzzles together. Okay? Freud, Erikson, Piaget, and Kohlberg are the ones that you're going to see. The first exam is going to have it on there. Something you need to understand. Now, I'm going to go over it a little bit today, but even more next week. So Freud is it's all about psychosexual. What do you think about sex, basically? Oral, infants, why is it? Well, how do infants soothe themselves? By their mouths, right? Pacifier, fingers, thumbs, toys, anything, everything in the mouth. They explore the world in their mouth. So that's oral. Then why anal for the toddlers, ages 1 to 3? They're potty training. So it's all about, anal. 3 to 6 years old, they find out that they have a penis or a vagina and they go exploring. And then latency is all about figuring out, same-sex peers and friends, et cetera, and wanting to do goods. And then, of course, when they become adolescents, what are they thinking about? They all about sexuals and genitals and, being with whoever they want to be with, right? Now, Erikson is the one theorist that's on most HESIs and on most NCLEX, okay? And there are all the areas. Again, remember, there's infant, toddler, preschool, school age, adolescent. There's all those levels. And according to the age, they do different things. And I'm just going to do the first two for you, just to give you the understanding. Trust versus mistrust. Why would an infant have trust or mistrust? What does an infant do when they want you? They cry. What happens when they cry? Usually, somebody goes and gets them, gives them back their pacifier or pats them or picks them up, burps them, change them, feed them, right? That's trust. They trust and know when they cry, somebody's coming for them. All their needs are met. Mistrust. There are times in many different types of situations where they don't get anybody coming to pick them up when they're crying. And it gets to the point where they stop crying because they know nobody's coming. That is a mistrust. Now, toddlers. As I said, my dive bomb kids. This is ages 1 to 3. Autonomy versus shame and doubt. Well, what does this mean? What is autonomy? It's being autonomous. It's all about me, egocentrical. Me, mine, I do. They don't want anybody to do anything for them, and they don't want to share toys, correct? That is a toddler, all right? But what's the shame and doubt? That is the mother screaming when he's on top of the couch and he wants to jump and doesn't let him do it because they're going to get hurt. So they didn't have the chance to try to learn from a mistake. Now, of course, if it's going to cause danger, you're going to stop them. But if you're always stopping them, not letting them do what they want or want to try to do, then what do you want me to do, right? They have to. How do you learn? By trial and error, by trying it, right? And if you don't let them try, that is your shame and your doubt. Okay, that's the start of Erikson. Now, Piaget is more about thinking and putting that thinking together. So, as I said, there's fine motor skills with the fingers. And we know that the first thing that an infant does is a reflex grasp. You put your finger in there, they might grasp on it, and it's a reflex. They didn't do it on purpose, it just happened, all right? And mommy's gonna go, oh, look, my baby's hugging my finger. Isn't that sweet? Don't tell them it's a reflex. Let them think that their baby is hugging their finger, okay? Well, then it gets to the point where it's voluntary, palmar grasp, it's called. And they get the rattle and put it in their hand. And then all of a sudden, they move their hand and it makes a noise. Oh, I like that. Let's shake it some more. Then they put it in their mouth and they know they like it in their mouth. They're learning from just a grasp. Do you see how you build upon it? And then you get your pre-operational where they throw their rattle on the floor. Mommy comes and picks it up. You know you want mommy? Throw it on the floor, their sippy cup, the bottle, whatever. Their mommy's gonna come and get it, and you got your mommy. Now, do you see how this built upon each other? And that's the start of Piaget. Now, we know that at first, infants coo, and we know that they cry. Those are the first things they start to do. And we know that that language is important, okay? And that we, respond to it. Kohlberg is all about right and wrong. Just think about right and wrong. And as they get older, it's the consequence for that right and wrong which guides their action. And as they get even older is, I got to do it wrong. Is it worth the punishment? Okay, it is. So now I'm still going to do it. They start to figure out right and wrong and the consequence for each, okay? Kohlberg. What do kids do every moment they're awake? They play with whatever, right? Ever put a kid in a room with a toy box? By the end of the day, what does that room look like? Every place, everywhere, there's stuff. I can't even tell you how many times I was walking on Legos when my children were small. It's just, darn kids. I missed that one, right? So what you need to know is there's different types of play. Social affective is being around other children. Sense pleasure, it's like sand or mud. You like the pleasure of the feel of it. Skills, building a blocks, making something by themselves, or it could be pretending to be somebody. And of course, there's always those games. What do toys do? What does play do? Well, play starts them cognition, learning about things. Also, if you put it in front of them, they're going to try to move and get there. So now you're stimulating muscle movement and, I want that. I'm going to try to get there and I'm going to get it, right? So we know toys are sensory oromotor, which means the touch in the mouth or moving it around. That's the basis for play. That's exactly what you want on whatever different level of every child, any age. It helps with their smarts, their intellectual. As they get older, it's socializing with other kids. Now, remember the toddlers, they're like the me, mine. They don't play with other kids, but they play next to each other as we call parallel play, right? So, but they're watching what each other's sort of doing, but they're not sharing because it's mine. I'm not sharing with you. And then it also teaches them more about themselves, etc. So these are the types of play. You're going to see this again and again and again. Onlooker, what do you think it is? Well, I'm looking at you play, right? You're not partaking, but you're looking. Solitary, I'm in the corner playing by myself. Parallel play is that toddlers. Always, when you say parallel play, you say those are toddlers. They're playing next to each other, parallel, right? But they're not sharing and they're playing with their own toys. Now, associative play is when you get to the preschoolers. And now they're playing together with all the toys, but there's no goal. There's nothing to reach for. No, there's not a winner in the end, okay? Cooperative play, children playing together, and there's going to be a goal. Whether it's older kids playing checkers, somebody's going to win, or let's build a house together with the Lego blocks. And they build the house, and that was the goal. So cooperative play, there's a goal. Associative play, they're just all playing together with no goal at all. As I said, toys are great, sensor or a motor, teaching them touch is feel. It's about movement, the way things move and how to do it, push, pull things, right? And it brings kids together. And, having parents down there on the floor in those tummy times, it's a good time for the parents and the children together. And as I said, they're moving, they're pushing, pulling, moving. Now, how do you assess a kid, it can be very hard to look at it, but the first thing you need to know is what are those developmental milestones? And those could be simple, those gross motor skills and those fine motor skills in that first year. Those are literally your milestones to look for. It's harder to check for children with disabilities. And again, you need to know what age is the kid and what's expected of the child. Because a 5-year-old's different from a 3-year-old, right? They are aware of different things. Children can be born with all sorts of deformities, clubbed feet, missing an arm, a leg, all different stuff. Could be syndromes, or it could be due to some outside influence. Could be genetics, right? I always think of genetics. I think of, Downs is either 21, chromosome 21 or 18, right? Then you have a Q22 deletion. So to George, I mean, all these different things are all that genetic disorders. And again, it could be caused by something. Now, what do we need to do when we're getting all this information on these kids? It's if we're taking care of a kid, let's say that has the George syndrome, per se. Now, the George syndrome is a cardiac kid, actually. Usually it's a right-sided cardiac condition. Usually they have a tiny little jaw. Usually they have feeding problems. Usually they have pointed little type of ears and a little tiny little, the jaw here. These children can have problems eating in the future. There could be cognitive delays, and we need to search to see if they have any right-sided cardiac, deformities. Could be a tetralogy, could be even more than that. So these are things that we need to tell these parents what we're looking for and why, and what do we know about it. It's also teaching them they want another child that they have a syndrome. They need genetic testing before they have another child to determine are they going to have another one, right? And again, one of the things you have a kid, let's say you have a child born with a cleft lip. Parents didn't know it was going to happen. I don't know if you've ever seen an infant born with a cleft lip. It's not pretty to look at, So what would I do? I would say, oh my God, look how much hair this kid has. Oh my God, this kid's got big feet and hands. Or look at those pudgy cheeks. Try to promote the bonding because sometimes they're afraid to touch them. I've taken kids with myelomeningocele, we'll get in later, pick him up, wrapping and put him in the parent's arms to promote that attachment because not only does the parent need it, the kid needs it, and the kids do know. Now, this question is all about, using different things, but what I want you to take from it is the answers that are back here. Object permanence is something that infants have, or even older kids. You take the toys at the end of the day and you put it in the toy box. Doesn't that child know, the older kids know it's still going to be in the toy box? I can find it. Infants. Let me say you have a rattle and you put it behind something. They still know it's there, even though they can't see it. That's object permanence. So they know to start shimmying and trying to wiggle and try to go get it, right? Because they know it's got to be there. Because I just saw it. It's got to be there. And then we'll get into pre-operational and concrete, etc., as we go forward. But the first one I wanted you to know was object permanence. So let's go into assessing children. Now, one of the things about pediatrics is 18-year-old children can have sign for their own everything. They can sign their own consents, and you need their permission to talk to the parents about telling the parents anything. Parents can't call up and ask for their 18-year-old child's lab results. They can't because the 18-year-old, it's HIPAA. That's one of the things that's really tricky. As long as they're alert, cognitively aware, that child is responsible for himself. I've mentioned several times talking to parents, and it can be really hard. One of the things is making sure you're talking to the person who's going to have the information. I've had groups, 8 people come in with one child with a fever, and they were with the aunt all weekend. And the mother's trying to answer questions, but asking the aunt, but so when did you do that? Oh, when did you do that? I'm like, wait, wait, let me just talk to the aunt. Is that okay with you, mom? Getting permission, right? Again, HIPAA, getting information. And also, do you mind if we talk in front of all of these people, right? And that's cultural. It's absolutely cultural that you had to find out. Also, you got to direct the focus. What's going on this time? I don't need to hear an 8-year-old child coming in with a fever, a little upper respiratory. What happened at birth if it was not significant at all? And some parents all want to tell you every little thing that's gone on. I'm like, okay, let's go to what's going on now. You need to know immunizations, allergies, any medications given, any chronic conditions, what's going on with a kid today, right? That's what you need to do. And one of the things I have learned, one of the best things, especially on your young infants, is to be empathetic. And what does that mean? Well, I used to work weekends in the ER on the day shift. And I know that some of these parents had been 2 times to the doctor already that week to the urgent care, and they're not getting what they need. So they finally come into the ER. They're working, they have other kids. These mothers look exhausted. And I'd say, Mom, are you okay? You look tired. Wow, you've already done a lot for your child. And they would go, Yes, I'm exhausted. I said, Okay, I'm going to help you. Let's get treated your child. Let's take care of it so that you can get rest and so can your child. And just saying that, you're going to have a parent appreciate you because you're understanding they are suffering too, because that's what it is, right? It happens. So being empathetic and silent, and again, open-ended questions and let them talk to you. Talking to kids. Talking to kids, you can't go in and just talk to a toddler. They're going to scream, yell, and go into mommy's or daddy's arms, right? So how do you do it? Well, minimal contact at first. Now, this picture shows somebody sitting on the bed, but she's a little bit higher than him. I would sit on a chair next to the bed. So I'm looking up and they're looking down at me. I'm not threatening now. And then I'm going to open the conversation with maybe some play or, oh my goodness, look at the freckles on you. Or, wow, you've got huge eyelashes. Or an older kid, wow, you're wearing a Spider-Man shirt. You like Spider-Man? What do you like best about Spider-Man? Or older kids, so are you in school? What's your favorite subject? So I'm breaking the ice. I always had stickers in my pocket. So I say, you want a sticker? Which one would you like? Okay. Now, I've opened it up. I'm on their developmental level at all times, talking in words that the children understand. And the younger kids, I'm using play to do everything I need. And they will behave and they'll listen to me because I am now non threatening. Because working in the ER like I did, I could have 40 kids in a day. That's how quick this place was. And if I had to chase every kid down the hall to do something, I would get nothing done. Taking 2, 3 minutes, playing with these kids, sitting, talking, taking my time. Now the kids trust me. And now they want to follow me around wherever I go in the ER because they trust me and now I'm their friend. Okay. So, very important part. At first, minimal contact. Get on their developmental level and explain procedures in a way that they understand. We've already talked about history taken, talking to the parents, finding out what they need, etc. With adolescents, one of the tricky things is many of them not going to talk in front of their mom and dad, especially if it has to do with, let's say, frequent urinary tract infections on a girl because it's due to sexual activity. And mommy and daddy don't need to know that that's going on. You can ask the parents to leave the room. And you don't have to tell them what that child told you unless it's something that would harm themselves or others. Okay? And again, you got to build rapport up with this adolescent because remember, you're an adult too, right? You're still a threat. So, I would always, oh, you're listening to music. Who do you like? Or they'd have like really cool sneakers on. Or you say, where did you get those? Those are really cool. Or how's school? Or you see a sports jersey on, something, talk to them. And then again, same thing. They're going to talk back and they're going to try to tell you things. And I'm telling you, adolescents, their favorite thing to do is to try to shock you, coming out with something that you're like, what? Anyway, again, going over those things, like I said, making sure we know what the needs of a family is, again, culturally, what foods, what do they need, very important. Now, doing that physical examination, you're going to do no head to toes on a kid ever. Sorry, it ain't going to happen. If you have an infant, a small child asleep in a mother's arms, listen to their breath sounds and heart sounds while they're still asleep. You might have to come back in 5 times to finish an assessment, but it's not going to be head to toe right away. So try to do what you need to do focused initially, and then get the rest in when you can do it. Okay. Again, making sure when anything's going on with that kid that they're prepared properly, that they know what's going on, they know what position they're going to be in. If they know those things, they're going to be less afraid. We're going to be doing all of these things with these kids. Abdominal circumferences and head circumferences are not really popular in adults. We don't really do them much unless abdominal due to, maybe some ascites or something in the abdomen. But in infants, we check it every shift, especially if they're feeding to make sure the food's there. And we're checking head circumference because we want to make sure that it's not getting bigger or maybe water building up there, right? And we're going to go through the whole thing. Now, we're going to be doing a heart rate by a apical heart rate. Your book says up to age 2, then you could do radial. I've read other information that said up to age 5, but by age 2, you can be doing radial pulses on them. Again, general appearance is really, really big. Many times it's kids just looking at them, and kids are very honest. When something's bothering them, they hurt because they're coming in, they'll show you. And it just sometimes breaks my heart when they say this ear hurts, you know. Making sure we look them over completely. Sometimes it's just walking, you can see them limping, something's going on. Remember, the head is always big at birth, and it should about equal the chest about a year and a half old. So at birth, they've got big head, smaller chest, and by a year and a half, they should equal. And abdominal circumference, it shouldn't be increasing by 2 centimeters in one shift if we're monitoring those things. Proper heights are difficult on your younger kids. They think that wood's going to come down and bop them on their head. Again, make it a game, pull it down, say, okay, go ahead and touch the top of their head with it. Have them do it. Look at the number. I would say, well, my number's a 7. Okay, you do it. Here, hold it. Tell me when you hit your head. Okay, what number are you? Oh, you got an 8. You beat me. Make it a game. Have fun with it. We do blood pressures, all different size cuffs, all right? I like doing D on your toddler and your preschoolers on the lower leg because it doesn't hurt. I mean, think about you getting one in your upper arm. I mean, it pinches my fat and it hurts. I wish they could do it on my leg too. And then pain management in children. You know, children are still suffering. And it's because we're not giving proper doses. We're not going back and checking on them. We need to do distraction techniques in there and we need to monitor them. You give something for pain, you do an intervention, you need to go back. Did it work? Did it not work? Okay. And kids don't tell you they're in pain. Why? They don't want a shot. They don't want to take medicine. So they're not going to say, I hurt. Okay. So making sure they understand many times there's an IV, it just goes in the IV. I'm not even going to touch you, but I'll take your pain away. Now there's 3 scales that we use: numeric, faces, and FLAC. All right. Now, numeric, according to your book, is ages 8 and up. This is from 0 to 10. 0's no pain, 10's the worst in the world. Okay. I'm telling you, kids that are 4 and 5 can tell you this number, but the book says 8. FLAC, nonverbal, and kids under 3 years old. Infants, toddlers, nonverbal is FLAC. And we look at the facial expression, their leg movement, their activity, cry, and consolability. That's the FLAC. And then we have faces. Faces is this scale right here. From 0 to 10, children will point to where it is. And this is preschooler, ages 3 to 8 for faces. So FLAC is 0 to 3 and nonverbal. But age 3, it starts the faces, okay? And then at 8, of course, we have numeric. Remember, there's all sorts of pain. It's something that you started to understand in pharmacology, and kids do have pain, and we need to treat it. It does. Can you imagine being in pain all the time and, you know, it's not being addressed? I mean, I know with rheumatoid arthritis that I know that if you're not addressing it and you can't move, it can depress you. Children are the same. Remember, when we're doing pain management, it's just not that medication. Remember, children, distraction. Give them a coloring book, give them stickers, turn on a cartoon, give them an iPad, give them a game to play, right? Color, something. Those distractions really, really help. Another thing that we could do is positioning, you know, elevating the head of the bed if they've had to, like appendix surgery, giving them a little pillow for their tummy, hot, cold, swaddling infants. All of these things can help. I mean, this mother's doing kangaroo care. Premature infants on mommy's breast like that, skin to skin, you're going to see them with the lowest heart rates, lowest respiratory rates, sleeping better than they do in their little warmers or isolates. It's quite amazing. And remember, it's just not the narcotic, although morphine is used for bad pain in children from birth. It can be given very, very, very safely. But remember, there is Tylenol, there is ibuprofen. Now, ibuprofen cannot be given until they're 6 months old. Has to do with some platelet aggregation, some bleeding stuff. So ibuprofen cannot be given until 6 months, but it's your acetaminophen, your Tylenol up to that point. And older kids can have that little pump and they can use it if they've had some big surgeries, and it does work really well. Kids are good with it. You know, taking care of pain. I mean, this little girl had some numbing cream on her arm with a Tegaderm, that plastic on there, and she's going to have her blood drawn. She's smiling. And you know why she's smiling? She's not going to feel the needle. She'll feel all the touch. She's not going to feel the pain. She's happy. Remember, pain comes from everywhere. I think ear aches are one of the hardest things they come in with that hurts, but it could be all different things. Remember, we need to help. Infants, giving them a pacifier can eliminate pain. There was a study done by Harvard neurophysiologists that looked at morphine versus a pacifier with sugar water on it for pain relief in circumcisions. And they found out there was no difference between morphine or a pacifier. My grandson had it done with a pacifier, and he cried a little bit, but probably because he was strapped down. He didn't want to be strapped down for the procedure. So remember that pacifier is a pain reliever. So, which of the following is an important factor to consider in understanding the pain experience in children? Which one?
Is it A?
No, they can tell you.
Okay. B.
The
They're
B.
not going to admit it, right? They don't want the shot. They don't want the medicine. They don't like it. They're not going to tell you, okay? Narcotics are safe if administered milligrams, micrograms per kilogram. And children's pain is just like adults. And we're just really getting to the point. One of my biggest pet peeves was children hurting and not getting anything for pain. They had surgery and no infants, even premature. Why did you giving this kid something? These kids hurt. And it does, and it's very safe. In fact, morphine's probably one of the safest drugs, narcotics, in children, because it's been around forever, hasn't it? All right, let's go ahead and do our little Kahoots, get her done, and we'll be done for today. Any questions so far? Who wants to win Kahoots today? You know, after this goes for a while, you're going to find yourselves being very competitive. I think Sarah wants to win. I saw a smile. Or McCormack. Yep, there you are too. Okay. You're one of those? No problem.
Just a little.
I could see it. You know, these are fun. Have fun with it. They're not graded. You know, again, I do explain stuff as these questions come up. If you're still not understanding why those answers were it, please stop me and ask, okay? I don't mind. Anybody else joining me? Just go up to that little
I'm
thing up
coming.
top.
I am.
I'm
Yep.
trying to.
Just go to that little thing on top and on your photo and click it and you go right in. I just learned that last quarter. I didn't even know that. And I've been using Kahoot since 2019. All right, we're going to get going so that we can get out at a decent time. I promised you. There's 34 questions here. From a worldwide perspective, infant mortality in the United States, that means infants who die, related to the world, are we good or bad? Remember I told you we should be farther than we are. It's higher mortality.
gosh.
More infants die in the United States than many other countries. Yeah, we got a long way to go. But we're getting there. I've seen progress. The leading cause of death from unintentional injuries in children is. Did I tell you most of the injuries in children are all ages? And it's motor vehicle. And you know, I can't tell you how many children I've seen come in, toddlers, preschoolers have been ran over by cars. I think it's probably one of the reasons why we have backup cameras now, because of that, truly. Which statement is most descriptive of pediatric family-centered care? What is family-centered care? Remember, you're taking care of a family.
Voice family.
Remember, all this kid knows is a family. It's the only constant. They don't know anything else. So remembering that and trying to fit in the family schedule as we get next week, you'll understand that more, make even more sense for you. The major cause of death for children older than 1 year old is remember, kids older than 1, they don't have a filter. They don't know right and wrong. They're exploring the world, right? It is unintentional injuries. It's that dive bombing in places where they shouldn't have done it and they get really hurt because they don't know better yet. The nurse caring for the child in pain understands that distraction. I said, give them some stickers, give them a coloring, give them a cartoon on TV. I mean, sometimes I turn the music on and start dancing around in the room and make them giggle. And then they start at least moving the arm with me. Little things. I told you I went to work and played. Remember, it has to be appropriate to the child. You can give, a 1 year old, an iPad. They don't know what to do with it, but you can give them a cartoon on TV or music. They can work with that. So remember, always appropriate developmentally for the child. In what type of play are children engaged in similar or identical activity, but without organization or a mutual goal? They're just playing. They're all together, they're playing. It's called associative. Solitary alone. Parallel is what we call the toddlers. They're next to each other. They're not playing. Remember, they don't share. Mine, mine, me, me. Associative is that. And cooperative, there is a goal. They're playing together. They're building a house. They're playing checkers. Somebody wins. These are important things. You're going to see them again. Which statement best describes the process of critical thinking? Did you have in your orientation in nursing school about how you're going to be taught how to critical think? And you're like wondering what this critical thinking all is? Well, didn't you all come to class? You know where to go to look to get the Zoom to come in? That's critical thinking. When you go to the refrigerator to make something to eat, you check to see if everything's there before you make it. That's critical thinking. So don't think of it as a big thing. It's looking at what do you have and what's your outcome you want and how you get there the best way. And that's purposeful and goal directed. What is probably the single most important influence on growth at all stages of development? What do you need to grow? Nutrition, nutrition, nutrition. Yes. Frequent developmental assessments are important for what reason? Why do we have to look at fine motor, gross motor skills? Are they doing what they should be doing? Are they gaining weight the way they should? Or what? Why do we need to know that? Why do we look at that? Because we know that there's certain things they should be doing. And if they're not, there's delays. And then what do we need to do? Of course, tell the physician, but early intervention. The earlier that we do it, the better it is for the kid. Which function of play is a major component of play at all ages? It's sensorimotor activity. So it's the touch, it's the feel, exploring the world in their mouth, moving it around, which is creative and socialized and in intellectual development. But it's that touch that, exploring it and how it moves and it functions is what the big major component is. 3 children playing a board game would be an example of what? It's cooperative play. Associative play is not a board game. They're all playing together, no goal. Cooperative play, somebody wins, there's a goal. The head to tail direction of growth is referred to as cephalic is head, right? Caudal. So you lift your head first, and then you roll over front to back to front, crawl, creep, walk. That is head to tail. Cephalocaudal. What is the single most important factor to consider when communicating with children? Developmental level. Absolutely. You can be explaining them above their head, they're not going to understand. So making sure that they do understand it on their level. What 2-year-old child pain assessment tool should the nurse use? 2 years old. Which one? So from 0 to 3, it's FLAC and nonverbal. At 3 years old, it becomes faces. You need to remember that. You're going to see it again and again and again. These are the ones that you'll see on HESI and NCLEX and exams, guaranteed. At 6 months, an infant's birth weight should do what? Again, we're always doing height and weight on children because we're looking for all different things. Are they getting enough nutrition? Are they, too much nutrition, too little? All these things are important. It should double at 6 months. The first expected fine motor developmental milestone for an infant begins with, remember, fine motor is fingers, hands. What's the first one that happens? It is that reflex, right? It's reflex. The finger comes and they grab it. They don't know why it happens. Then it's voluntary palmar grasp, okay? So now we have the hand grabbing it. Then it goes into, let's say a kid sitting in a high chair, and you put either Cheerios or puffy snacks, and they sort of smush it in their mouth, and that is called a crude pincer grasp. Then they get the fine or neat pincer grasp. Then they take and put objects into a container, and then they build a block of 2 by 1 year old. It's all about fine fingers. We'll go again next week. We're going to do it again. At 8-month-old, infants should be expected to perform which fine motor skills? So after I just explained all of that and talking about fine motor's fingers, which do you think they should do by about 8 months? So we should be able to grab, rattle voluntarily, and then now we're into the crude, like smushing the pincer grass. It's not into a little one like that yet. Objects in a container is 11 months, and blocks of 2 is 1 year old. Again, we'll go over it again next week with the infant section. The natural physical developmental sequence that most children follow, and this is gross motor skills. What do they do first? And they lift their head up first. All right, and then it's front to back to front. Then they creep, crawl, and then they walk. Which behavior indicates that an infant has developed object permanence? What did that mean? Object permanence. that even though you showed them a toy and you hid it, they still know it's there. Like the older child, the toddler, you put the toys back in the toy box. He knows tomorrow you're going to go in the toy box, it's still there, even though it's not in sight. So he actively searches for whatever was hidden. In general, an infant should triple their birth weight at what months of age? And that's at 1 year. So if you can imagine, kids born at 7 pounds or 21 pounds, they can't lift their head at birth, and now they're walking and running. It's quite amazing how quickly they grow. That first year is quite fast. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the exam. Remember, toddlers are ages 1 to 3. And you always go into a kid making sure that you are preparing it on their understanding, their developmental stages. Again, remember, minimal touch, and then on developmental age that they can understand what you're trying to do. According to Piaget, toddlers are in the what developmental stage? Remember, toddlers are exploring the world. And it's called sensorimotor. When you look at autonomy or trust, those are what we call Erickson. Formal operation is adolescent. So the only one with sensorimotor. And again, this is something you're going to have to look at. You're just not going to learn it in a day. It's going to take you going back and studying it. Which intervention helps a hospitalized toddler feel a sense of control? Children love to be on the same routine. I think taking a toddler on vacation is hard because they want their same routines. They want their bedtimes, their snack, same foods, the same everything. And it's difficult. It's the same thing like they go in a hospital. So try to follow as best possible their normal routines for feeding, bedtime, bath time, and all that. All children reach developmental milestones at the same age. Yes or no? Absolutely not. I'm telling you that by 1 year, children should be walking. My children and my grandson never walked at 12 months. At 15 months, they ran. There was no walking. Their first steps was 38. It wasn't one step. So, no, they're all different. Now, what makes it a problem? Well, if they're at 8 months and they still can't lift their head up, that's a problem. But as long as they're moving forward and met all the other goals, they haven't walked at 12 months, it's not a big deal. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for this infant? Atraumatic care, which means you don't want to hurt the kid. You want to decrease the pain. How can you comfort an infant? Again, this is the pacifier. Absolutely, give them a pacifier. When they go home, cool packs, moving their legs, pumping them as we call bicycling, and giving acetaminophen, yes. But during the procedure, the pacifier really helps. And if the mother's holding the kid, even better. Which of the following immunizations can be administered to a newborn? Now, you're going to see a chapter with a double page of immunizations. I'm going to try to let you know the ones that are important, okay? This is one that you'll see questions about. It's usually done at the hospital before they go home. And it's hepatitis B. You know, MMR is 15 months, DTaP, polio, those are, DTaP is due for 6 months, and polio at 12 months, 15 months. So you're not going to have know all of it like that, but Hep B, you do know. You have to know, and you need to know which one is a live vaccine, varicella. The normal heart rate for an infant is and that's 140 to 160. You were listening. Good job. What is the preferred site to give an injection to an infant? And the way this woman is giving this infant, I would be very upset. Somebody needs to be there holding the hands, right? And I would have the mother doing it. I just like the picture. It's called the vastus lataris, the upper outer thigh. First place we start doing it. We don't move them till later on. The death of an infant under 1 year old with no known cause. We'll talk about it more next week. I mean, it's mostly male infants. Smoking, co-sleeping, too hot, stuff in the cribs. No more bumper pads. And they used to be cute, but they can strangulate on them. And yes, it is SIDS. The Vietnamese mother of a child avoids eye contact with the nurse. Considering cultural differences, why do you think she does that? It's respect, you know, and you're going to see different things going on. And again, if you don't know, you don't understand, ask, and they will tell you. And actually, they'll be really happy you did. A child from Mexico is hospitalized for a serious illness. And the father says the child's being punished by God. Why is he saying that? Absolutely what the Mexican culture believes in. Common health belief. Which term refers to a time in individual's life when he or she is more susceptible to positive or negative influences? This is one of those things in the slide that there's those definitions for. And it's called sensitive period. Very good. What is characteristics of the pre-operational stage of cognitive development? This is at age 2 to 7. Remember, cognitive is Piaget, the way they think. How do they learn? Remember, they took the rattle and they shaked it and it made noise and they liked it. So thinking is concrete, as in they need to see it to understand it. They shaked it themselves. They knew it. That's what we call concrete. They've seen it. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? Now, preschoolers are ages 3 to 6. And they're starting to understand right and wrong, right? How do they understand that? Well, they know if they went to stick their finger into a plug, somebody's going to yell at them, right? So they know what they do, what's right and wrong, because they know when they're going to be yelled at. Children are smart, preschoolers are smart, so they won't do it. Number 3, LOL. Number 2, Will, good job, Will. Number 1. Mac, you did it. You came back. I knew you were gonna. Haley and Sierra. Boy, I called that one pretty good, didn't I? All right. So remember, you have your first thing to do is your discussion question. Again, you have any issues you don't understand, please, please, please contact me, communicate with me. It was a great class. Nice to see you all. Did I keep you awake? Did I give you enough information, enough stories? Because I love telling you my stories, and I do hope they help. Anyway, have a great night, guys. Thank you.
Thank you.
My pleasure.